مديني واحد بايظ معلش. We will open the floor for questions. We ask for the first speaker, Dr. Hazim. Dr. Hazim. مشي؟ I would like to comment on the low profile TIVAR. Usually after the recent studies, about 18% of patients need this TIVAR. Either due to access problems or whatever the indication of the low profile, only 18%. The second point is bird beak complication does not appear immediately postoperative in low profile, but it appears later during the follow-up. The second point is the advantage of the low profile is the short segment of the sheath, of the proximal sheath. So you can advance it all the way to the inside the arch for proper landing in the different zones of the arch. I'm asking if you are proctor for Bolton? Yes. You have the hooks at the proximal end of the graft? Yes. So hooks are not recommended, but they put hooks in the low profile because of instability. And there is reported cases of migration of the graft and persistent dilatation of the aneurysm, and the best result were observed only in those with ulcer or intramural hematoma or small saccular aneurysm. And the long-term results are not yet proven. What's your comment?
So, thank you. Very important question. Thank you for your question. So, first of all, about the low profile, actually, as I said, about 20 to 25% of patients have narrow access arteries, and the other persons have to have operation on the arteries. And don't forget that we have also a small and young patients, and the small and young patients usually have to have also very narrow arteries, less than 7 millimeter. From other side, the low profile, it's not also reduction of the relay pro. It's not also including the reduction of the induced system, but also has new features is the releasing mechanism, a new releasing mechanism through the handing grab. So we have here a combination of new features in this new stents. From other side, do you mention the hooks? Do you mention this as a bar metal stents at the proximal ends, you mean, sir?
Yes.
Or
yes,
yes.
The hooks
So,
are
yes,
not preferred in the
the bar metal stents. It's I usually take the bar metal stents only in case of aneurysm, because in case of aneurysm you need. I prefer a landing zone for more than 2 centimeters, and that's why you need an uncovered part of TIVAR to head a more fixation into the aortic arch. But in case of dissection, I actually use the non-bar metal stent.
And you know what? In the reported complications is retrograde dissection.
Yes.
To type A.
Yes,
and
of course.
You have to extend the proximal landing zone by another graft. This is one of the problems of the low profile.
It's very important here to emphasize that oversizing here should not be also should be respected here in term of dissection. As I said, take non-bar metal stents and oversizing only in 10%. And in case of aneurysm, I think you can take the bar metal stents with oversizing of 20%. Actually, I'm proctor for not only from Terumo, for other companies. But as I said, I prefer Terumo into the aortic arch, especially in zone 0. And for the last question about the futures of these stents, what we have here also is the reduction of transitory ischemic attack. I mean here the nerve system, because this stent or this deployment stance has double sheaths, and in the main or the first stage is advancing the nitinol stents, and the second stage is advanced the double sheaths. And in this stage, the stents itself will be washed through the flow of the blood. That's why I used to prefer this stents.
Thank you. Thank you very
Dr.
much.
Hazem. Because of lack of time, we are going to next speaker. Please, Dr. Ayman.
Dr. Yazin? The question for Yazin or for?
For Yazin or for Hazem?
I'm here.
Yazin, okay, you're in. I have a little bit of question, please, regarding and the rest of the floor goes to the guys, of course. Regarding how much you cover from the intramural hematoma. I mean, sometimes intramural hematoma is extending along the whole descending aorta, and sometimes extending even in the abdomen.
Yeah,
Where to choose? I mean, your CT, even the high resolution, failed to pick up an intimate disruption. From where to where? The diameter oversize. I mean, is there a lot of unanswered questions?
excellent question. No, the question, I don't think there is a clear answer. You need to do if your high resolution CT scan does not show where the intimal disruption is, of course intravascular ultrasound may help you detect some penetrating ulcer or an ulcer-like projection that was too small to be detected by CT scan. So aim to go for that. Now our strategy, even in type B aortic dissection, which I think intramural hematoma again is part of the spectrum, is to go for long coverage. Now, and we have, so what in our facility, for every patient who has a type B aortic dissection, we cover from the left subclavian to the celiac artery, only 2 centimeters above the celiac artery. So we go for long coverage all the time. This is the same strategy that we use in intramural hematoma that requires treatment. You're going to ask me about paralysis. We found that the incidence in paralysis is the same for short coverage and long coverage to 200.
One more comment. You underestimate the medical treatment and the observation of intramural hematoma. And as if you reach the conclusion, if anyone see intramural hematoma, go ahead and do TIVAR. And this is not accepted.
No, that is not what I said. I think most patients with intramural hematoma will eventually need treatment because they will develop complications. Around 40% to 50% of these will have a penetrating aortic ulcer or a focal intimal disruption that is considered a very high risk feature with a more than 50% risk of progression.
So now their name is not intramural hematoma. They shifted to another title of a penetrating ulcer or thoracic dissection. So it's not under the name of intramural hematoma. What I mean for our junior staff here, if anyone see intramural hematoma in the aorta and the patient is hemodynamically stable with less pain, try to observe, do a start medical treatment and follow up your patient. If you notice any complication, then you will interfere. And the second point,
correct,
let me say, the static CT angiography is not diagnostic. You do the dynamic CT to see if the intima is disrupted or not.
Yeah, no, absolutely true. But if you choose to treat a patient medically, which is the right answer in patients who are medically stable and have resolved pain, if they resolve their pain and they're hemodynamically stable, you're okay to treat medically, but you should have a CT scan prior to discharge, and you should have a CT scan in 1 month.
Sure.
Yeah. I have another question. Sorry. Sorry.
Please go ahead.
Thank you, sir. Yazan, thank you. As usual, great presentation. So, which size you prefer oversizing in this kind of disease?
Yeah, it's the same, 10% oversizing, just like you do with type B aortic dissection.
Yeah, I just wanted to reaffirm what you just said, because a lot of the people here still convinced, or they think that you need to just cover the initial tear at the left subclavian or the proximal tear rather than going all the way down to the celiac. Can you justify that? Can you tell us why you think that way?
The people who go for short coverage, they think that the risk of paralysis is less with short coverage. They're usually appropriately worried about that devastating complication. But we've compared it. The reason we treat all the way to the celiac is because the likelihood of a negative aortic remodeling in patients who have only short coverage, and therefore the requirement for further treatment is higher in patients with short coverage. And we've compared short coverage to long coverage in the incidence of spinal cord ischemia, and we found it to be the same. Not zero, but the same, as long as you take the other precautions, including hemodynamic management postoperatively, decreasing the incidence of bleeding postoperatively.
Thank you. Can we shift to the next speaker, Dr. Jamal? Any question for Dr. Jamal, please? Mic over there, please.
So, Jamal, where's he?
I'm here.
Yeah, Jamal, so is the endovascular, it's a constellation of skills, which means you don't have to have a lot of each, but if you do a lot of them endovascular, so you think it is the hospital, not the operator, or what for the open? Endo is different.
That's an important question. I think with open surgery, you can kill a patient.
Yes.
If you do a bad anastomosis, that patient's going to bleed. If you have any issues, that patient's going to show your problem. But with the EVAR, it's pretty hard to kill someone unless you end up with a major disaster and had to do a conversion in the OR. And I think that's why you don't see it. I think if you look at the results down the road and look at increased incidence of type 2 endoleaks and other complications, I think you may be able to find a relationship between surgeon's experience and hospital availability and hospital resources. I mean, certainly if you have excellent visualization, excellent C-arms, etc., you are less likely to get into trouble and cause problems. So I think that's why the studies did not show that in the EVAR.
Yeah, so that's my point. It's different into than open.
It is different. It's, you do a cut down, you do a percutaneous, you try to pass your device. If it worst case scenario, you have a type 1 endoleak. That's not going to show in mortality, in the immediate perioperative mortality.
Also, I have a question, Dr. Jamal, regarding this topic. Now, is there a limit of experience beyond which the annual volume to the operator does not matter anymore? And the reason I ask this, because as it is the experience of all of us, at certain stage, your work situation changes, that you probably moved into private practice or you moved on institutional work. You can't expect the same volume of work, and you cannot stop working because you do not have that volume. If we follow the advice, you probably shouldn't be doing that. But if there is an immune level of experience.
That's a very good question. And that paper that I showed about the experience of the surgeon, it showed exactly that after like 10 years of experience, the surgeons who had long experience, they did not need to have high volume. Even though they had a low volume, they were still able to maintain good results because their experience showed them how to get into and out of trouble. But at the same time, they were doing less ruptured aneurysms and less complex ones because of the change of their practice.
Excellent.
So I think that's and that's an important thing for the junior residents. Not to think, well, it's for the junior surgeons is to say, well, I won't have good results. No, you can have excellent results with someone who's fresh out of training if they are doing a good volume. But as you move higher with experience, you can get away with lower volume.
Excellent. Thank you. I do have a short question to Yazan, if I may.
Okay, sure.
Yazan, is there a point of making the difference between intramural hematoma and penetrating ulcer? Since all aortic wall pathologies, the treatment is the same, and there isn't enough data to say you treat this one or you treat the other. So probably we should lump them all together into aortic wall pathologies.
I think they are part of the spectrum, but definitely PAUs are a high-risk feature. Intramural hematoma can be benign to a degree in patients who have resolved pain and you don't have associated PAU. But in general, anytime you discuss one of them, you should tell the patient that you have part of the acute aortic syndrome or aortic dissection spectrum.
Would you shift to Dr. Fakhr al-Masri? Fakhr al-Masri, any question? Any question of Dr. Fakhr, please? Sure.
Can you tell us what your strategy is with juxtarenal occlusions? Do you also consider CRAB in juxtarenal aortic occlusions?
So the strategy, if the aortic lesion is more than 2 centimeters above the bifurcation, we consider CRAB because you don't want to kiss the two iliac stents higher than that. Most of these patients, they have peripheral vascular disease, so you want to maintain the anatomical bifurcation so they could go above and over in the future. So if it goes more than 2 centimeters, if you kiss them too high, you won't be able to cross over.
We're talking about the infrarenal part, juxtarenal.
Oh no,
juxtarenal.
Juxtarenal, you go for a tube graft. Just put an aortic tube graft, and then if they are combined with iliac disease, then you do the CRAB technique.
So it's not a CRAB, right?
Sorry?
You don't employ a CRAB in juxtarenal aortic occlusion, right?
No, yeah, you
don't use this.
You don't do that unless you use the AFX in the logics, which is a unibody.
Before going to last speaker, Dr. Ahmed Samadoni, lunch box will be distributed here. Please stay in this hall. Don't move. Any question to Dr. Ahmed Samadoni? No question. Okay.
Actually, I have question to Dr. Fakhr. So my question is, you use IFX into occlusive disease segments, but IFX is very soft. Do you reinforce your reconstruction?
Yeah, that's a good question. Sometimes we do place 2 bare metal stents, balloon-mounted bare metal stents, inside the limbs of the AFX to strengthen them. Yeah, that's a good question. And anytime you put a kissing stents, you have always the possibility of one overpowering the other one. So you keep an eye on that. And the best thing is to do a CAT scan in the future to see if one is impinged by the other iliac stent.
Thank you very much it was a nice session. Please keep staying for distribution of the lunchbox. Thank you much for your attention.
Thank you, chairpersons. It's the last session, which includes the venous part and many interesting lectures. And the last will be a nice debate about how to manage pulmonary embolism. I feel you are a little bit tired, so we will serve some supper for persons in the room. And I ask the chairpersons of the next session to come to the stage, please. Dr. Atif Halab, Dr. Ayman Fakhri, Dr. Fakhr al-Masri, Dr. Hussam al-Wakil, Dr. Hussam Rojdi.